A very good morning to all of you. So, I guess I'm live. So, welcome you all for today's session. I am Dr. Priyanka Sachdev here, and I wish you a happy Republic Day to all of you. So, today I'm going to discuss a very important topic here, that is transplant immunology. Now, this topic is important in pathology as well as microbiology. That's why intentionally I opted this topic to be discussed in the live session, because many students requested me to take this topic in the pathology as well as in microbiology. So I thought, why don't we take this topic in common in patho as well as in micro? So this topic is a little bit tricky. I don't say it's difficult, but it's little bit tricky. And you get many important MCQs from this topic in your competitive exam. This topic is also important for second prof university exam students, because you frequently get a short or a long note in pathology or microbiology from the immunology section on transplant immunology. So without wasting any further time, I must start this topic. Can I start it? Are you people ready? Give me a thumbs up in the chat box. Can I start? A very good morning to all of you. Yes. A very good morning to all of you. Can we start this topic? Let me share my screen with you. I guess you all can see my screen. Okay. So let's start the topic, the most important topic which I am going to discuss today quickly. Very quickly, we are going to discuss transplant immunology. So let's discuss the transplant. Now, first I will let you know what is transplant. Then I will let you know the classification of the transplant. There are two different types of classification. I will discuss both. Then I will tell you what is histocompatibility. Then I will tell you the various types of graft rejection, the hyperacute, acute, chronic, the mechanism of each of them. We will see the two mechanism of graft rejection, the direct pathway, indirect pathway. In the end, we will see the prevention of the rejection. Okay, so let's start. What is transplant? So transplant is the process in which we transfer an organ from the donor to the recipient. So either say organ or you can say a graft. So basically we are transferring a graft from the donor to the recipient. Donor, who's donor and who is recipient? We call the recipient as host. We can call the recipient as host. Who's the donor? Donor is the person, an individual from which we are taking the transplant. And the recipient is the person who is receiving the transplant. So you can see in every transplant, there is a donor and there is a recipient, and we are transferring the graft from the donor to the recipient. So two teams of surgeons are required working simultaneously. So preferably we take two surgeries in the same settings in the same hospital. Maybe this is a hospital. In the hospital, we take two OTs, two operation theaters in the same setting, in the same hospital. So two team of doctors work on them. The first team of doctor is working, the surgeons are working on the donor. They take the tissue out, they take the graft out of the donor. And the second team is ready with the recipient. So as soon as the graft is handed from the donor team to the recipient team, it is transplanted inside the recipient body, because we cannot keep the graft outside the body for long, because otherwise the autolysis will take place. We do not want that. So we want the donor and the recipient preferably in the same setting, in the same hospital. We want two different teams of the surgeons working on the donor, operating the donor, and working on the recipient. So as soon as the graft come out, it can be transferred from the donor to the recipient, and it can be implanted in the recipient very quickly. But sometimes it's not possible. The donor and recipient are the same hospital. Maybe the cities are different. For example, there is a person, the person is having the brain death. The brain is damaged, the brain death is there, and the family of that person want to donate all the organs. Now we want to take the kidneys also, we want to take the lungs also, we want to take the heart also, and the recipient of all these organs are present in different cities. Maybe the donor is from Delhi, the kidney recipient is present in Mumbai, the lung recipient may be present in the Bangalore, maybe the different cities are there. So in that case, the donor and the recipient in the same setting, same hospital is not possible. So we want to transfer the graft. We take the graft, we take the organ in a vital solution, so that autolysis is least. I will not say it is none, but it is least. And we want to transfer it as soon as possible. So we select the air route, or we make a green corridor, so we take the permissions from the government, from the traffic department and everywhere. And likewise, we make the arrangements and we do all this. Okay, so this is the introduction. I have told you the transplant. Now, let me tell you the classification of the transplants. We will classify the transplant into two ways. The first classification is based on the genetic relationship between the donor and the recipient, which is important. And the second classification is based on the anatomical slide of the graft. Let me tell you the first classification, based on the relationship between the donor and the recipient. Listen. What is the biggest problem in the transplant? You will say, ma'am, transplant is an easy process. No, it's not easy. The biggest problem is that we all have immunity in our body. Immunity. What is immunity? What do you mean by immunity? I simply call the immunity as army. The God has provided us with the army. So there are soldiers in the army. Who's the soldiers in our body that protect us from the terrorist? So there are B and T lymphocyte. There are two type of soldiers. The B lymphocyte and T lymphocyte, they make the army. So whenever any terrorist enters in our body, what happens when a terrorist enters in a country's territory? The army get activated and army try to kill the terrorist, to attack on the terrorist, to kill the terrorist. So that is the purpose of army. Okay. And so I call whenever any foreign particle, who's a terrorist? Any foreign particle enters the human body, I will call it a terrorist. Okay, the army of human body get activated in the same way. That is, B and T lymphocyte get activated and it try to attack the foreign particle and kill it. Now I'm saying there is a transplant. In the transplant, this is recipient. This is not donor. This is recipient. I'm saying this is recipient. So we are transferring the graft from the donor to the recipient. So this is the graft coming from the donor body. This is the graft. So it is foreign for this recipient. Okay, the antigens present on this graft are the donor's antigen. Okay, and this is foreign. This graft is foreign for the recipient. So in the recipient's blood, the B and T lymphocyte get activated and they will attack the graft and kill the graft. They will kill the graft. This is known as rejection. The graft gets rejected. We do not want that. So what to do? What to do to prevent it? We do not want the rejection. No? So we will keep the recipient on immunosuppressive drugs. We will keep the recipient on immunosuppressive drugs. So we will suppress the immunity by giving the drugs. It's a double-edged sword. You are suppressing the immunity so that the graft can survive. The graft is not rejected. But you are making the person prone for frequent infection. So the recipient will be prone for having multiple infection or frequent infection. So it is a double-edged sword. So post-transplant life is very difficult. If you don't give the immunosuppressant drugs, the person will have the rejection. If you give the immunosuppressant drugs, the person will have frequent infection. How many of you got it? Give me a thumbs up if you got it. Now the biggest problem in the transplant is the rejection. We do not want the rejection now. You tell me who's the best donor. Who is the best donor? So see, this is the donor. Okay, and this is a recipient. This is a recipient. Let me write. This is a donor. This is a recipient. You tell me who is the best donor so that graft is not rejected in recipient. I want no rejection. Who's the best donor? Say, ma'am, the best donor in that case is the self. Why don't you take a graft from the same person and implant in the same person? So the tissue will be same, the antigens are same. So body will not recognize it as a foreign and there is no chance of rejection. So is it possible? The donor and recipient, rare of the rarest case, it can be same. Yes, sometimes it's possible. For example, I'm having burns over here, over the face somewhere. Okay, so we can do the plastic surgery. We can take the skin from the back or the skin of the thigh and transplant it over the face. So who's the donor? Me only. Who's the recipient? Me only. So will my body recognize this tissue as foreign? No, it's my own tissue. It's my own antigen. Okay, body will not recognize it as a foreign. So if we transplant the skin from some other side to this side, there is no rejection. Body will not identify it as foreign. So this transplant is the best transplant. Okay, because there is no chance of rejection. This transplant is known as autograft. Auto means self. The donor is self, the recipient is the self. So it is autograft. Autograft, no chance of rejection. Only the site is changed from one side to another. But it is possible. Yes, absolutely right. It's skin grafting. So it is possible in rare cases only. It is not always possible. Okay, so the best transplant is the autograft. Autograft, in which the donor and recipient is the self only. Only one person is there. Okay, the donor is the same person, the recipient is the same person. So there is no chance of rejection. The example I told you. Okay, now I told you it is not always possible. Tell me the next best possibility. So this is the donor. Okay, and this is the recipient. Okay, I do not want any rejection. Okay, I want to take the graft. This is the graft. From the donor to the recipient, I want to transfer. This is donor and this is recipient. But after transferring, I do not want the rejection. I do not want the rejection. Now the antigens present are foreign. Now, if the antigens are foreign, the rejection will be there. I do not want rejection. So best transfer is the self. But self is not always possible. So who's the next best? Who's the next donor? Next best donor, I mean, in which the chances of rejection are nil or minimal. So the next best donor is the identical twin. It is the identical twin of a person. If someone is having identical twin, who's the identical twin? The monozygotic, monoamniotic, monochorionic twins. So they are genetically similar. Both these individuals are exactly similar. They are genetically similar. So if you take a graft from the one of the identical twin and transfer it to another twin, the twin, this person, the recipient will not recognize it as foreign because both the persons are genetically identical. So here also chances of rejection are nil. So there is no chance of rejection. This transplant is known as syn graft, okay, or also known as isograft. So iso or syn is between two identical twin. Please mind my words very carefully. I'm saying identical twin. I'm not saying non-identical twin. Okay. How many of you have identical twin? I don't have. I'm having siblings. I'm having my brothers, sisters. But we are not twins. We are not rather identical twin. Okay. So everyone don't have identical twin. I mean to say identical twin is very rare. Okay. What if I need a transplant in future? Who's the next best donor for me? I don't have identical twin. So this transplant we got it. This is isograft or syn graft. Here also chances of rejection is nil. And here the donor is the identical twin. Okay, genetically identical person. But if someone don't have it, then who is the next best donor? So see, this is the person, this is the donor, and this is the recipient. Okay. The best graft is the autograft, the self-donor, the self-recipient. If it is not possible, the next best is the identical twin. But if it is also not possible, the third possibility, the third best. Who's the third best? Who's the third best? This is donor, this is recipient. Who's the third best donor? The third best donor is any human. At least the species is same. Any human. I will say the species is same. Any human. Okay. It can be a relative, it can be a friend, it can be an unknown person. If multiple donors are available for the same recipient, we will do the HLA matching of all of them. So we will see the percentage of the matching and we will see maximum percentage matching is there. So minimum chances of rejection, we will select that donor. Got my point? So this type of graft is known as allograft or also known as homograft. Homo means same species. So next best donor is allo or homograft in which the donor is of same species. And finally, the worst graft is from animal. So it is not human. The donor is the animal. This is the animal. It is an animal. This graft is not performed nowadays because we have better options available. This is the recipient. So if we take some graft from the animal to the human, you can see some animals. So different species is there. The donor is from a different species, not a human. This is known as xenograft, also known as heterograft. How many of you got it? Xeno or heterograft. Okay. So this is also worst graft. Maximum chances of rejection is there. So based on the donor, there are 4 types of graft. Who will help me? You got it? Everyone got it? Give me a thumbs up in the chat box if you got it. So based on who is donor, who's donor? There are 4 types of graft. 1, 2, 3, 4. Tell me the 4 types of graft based on who is donor. The donor is same person. है ना? The donor is the self. What is the name of such graft? The donor is the identical twin. What is the name of this graft? The donor is any human. Human means same species. I will write here same species. What is the name of this graft? And the donor is the animal. By animal, I mean different species. What is the name of this graft? So we have 4 types of graft. So tell me the names. You get MCQs on that. You get MCQs on that. Yes. So if the donor is the self person, only the site is different. It is known as autograft. Very correct. Very correct. You all are right. If the donor is an identical twin, it is known as isograft or syngraft. Learn both names. If the donor is from same species, that is any human, whether the person is friend, relative, unknown person. So it is known as allograft. This was auto. Don't get confused. This is allo. Allo also known as homo. Homo means same species. Okay. And if the donor is an animal or different species, it is known as heterograft, also known as xenograft. Xeno or hetero is one and the same thing. So first learn the classification of the graft, classification of the transplant. So this classification is based on the donor. Who is the donor? If I need a transplant, who will donate to me? So based on the donor, there are 4 types. Okay. Out of this 4, please mind it very carefully. There is no rejection in the first two. In the autograft, there is no rejection because the person is the self. You take my skin only and transplant to me only. Who's the donor? Me. Who's the recipient? Me. So will my body reject it? No, not at all. There is no chance of rejection. 100% acceptance. Okay, if I wish if I had an identical twin, if identical twin give a graft to me, then also there is no rejection because the two identical twins are genetically similar. So if you take the graft from one identical twin and give it to another, another will not recognize it as a foreign. So again, there is no chance of rejection. But in case of allograft and xenograft, rejection is there. Yes, there is rejection, there is rejection. So rejection is the problem in these two. We don't perform this graft nowadays, animal graft. So maximum rejections are in allograft. So rejection is the problem in allograft and you get questions on that. Okay, so please understand it very carefully. So this is the 4 types of graft, you got it, and you got the same in the form of the diagram here. Can you see? If the donor and the recipient is the same person, it's known as autograft. If they are genetically identical, you can see the color. It's known as thin graft or isograft. If the two humans are there, but genetically not identical, they are only human, same species, it is allograft. And if the animal is there, it's xenograft. Okay, let me ask you a question. Tell me the type of graft if the donor is the identical twin. You all know that. But tell me the type of graft if the donor is the non-identical twin. Non-identical twin. Once there was a question on non-identical twin and students got confused. Tell me the type of the graft. If the donor is the identical twin, what do you call such graft? And if the donor is non-identical twin, what do you call such graft? You tell me first. Who will tell me? Can you please try? If the donor is identical twin, the type of the graft is known as isograft or syngraft. We all know that, Anna. But if the donor is non-identical twin, what is it known as? So they are two humans only. I will consider them two humans, which are genetically not identical. Okay, so two humans only, I will put it in allograft or homograft. So if the question comes on non-identical twin, go with allo or the homograft. Yes, absolutely right, Pseudopodia. Yes, absolutely right, Bisma. Absolutely right, everyone. Yes, yes, yes. Yes, everyone is correct. Absolutely right. So you get questions on that. Okay. Now please read the question and tell me the answer. Graft between identical twin. I guess everyone knows the answer. Is it autograft, isograft, allograft or xenograft? Between identical twins they are asking. So yes, you all know the correct answer. Yes. What is the correct answer? The correct answer here is, of course, isograft. Because they are asking between identical twin. So correct answer here is B. But if I change the question a little bit, instead of identical twin, I do a non-identical twin. In the same question, answer will become allograft. In that case, the answer will become allograft. So you get simple questions like that. Okay. One more question is there. Tell me the best example of syngraft. What do you mean by syngraft? Is it the graft between two dizygotic twin? Is it the graft between two monozygotic twin? Is it the graft between two members of the same species or different species, or is it two sides of the same person? So syngraft means between two identical twin. Identical matlab monozygotic. Identical means monozygotic. Yes, the correct answer is B and you all are right. I'm very happy that you got the concept. Right. Now if I change the question to allograft, answer will become C. If I change it to autograft, answer will become D. Likewise, we can change the question many times. Right. Now what is histocompatibility? Histocompatibility means if both of them are identical twin. These two are identical twin. So here these two are histocompatible. Means the antigens present on this are same as antigen present on this. So if you take a graft from one person and transplant it to another person, so antigenically the graft is same. Body will not reject it. It is known as histocompatible. It is only possible in case of identical twin. And in rest, all the other human being, if they are not identical twin, it will be histo-incompatible, in which the chances of rejections are there. So histocompatibility is seen in autograft and isograft, but histo-incompatibility is seen in allograft and xenograft. I hope you all got it. Now the problem with the transplant is the rejection. What is the problem with the transplant? It's rejection. See again. So this is donor. Okay. And this is recipient. Okay. This is recipient. Okay. Let me write. I told you 2 teams of surgeons are required. This is donor and this is recipient. We want to transfer the graft from the donor's body to the recipient's body. So I told you at the initial of the lecture only, we want the same setting, same hospital in which 2 OTs are there. So 2 teams of surgeons are required. One working on the donor, one working on the recipient. These are not identical twin. These are 2 human beings only. Okay, now just suppose you are working in recipient's team. You are a surgeon, and you are working in recipient's team. The donor team have handed over the graft to you. The graft is in your hands. Now you are transplanting the graft in the recipient's body. So you are transplanting it in maybe it is a kidney graft, for example. You have taken out the kidney from the donor. The donor team have done that, and now you are in recipient team and you are transferring the kidney into the recipient's body. So sometimes what happen na, as soon as you do the transplant, before you suture the patient and shift it to the ICU, shift it out of the OT, on the OT table itself, the graft is rejected. Yes, it can be as fast as possible. Sometimes it can be very fast. It can be very fast. Yes, on the OT table itself, you can see the graft is rejected. With your naked eyes only, you can see it is congested, it is rejected. So on the OT table only, you decide it's a gone case. It's a gone case, the surgery was unsuccessful and you have to take it out again. And sometime after the suturing, maybe within next 24 hours, you come to know that graft is rejected. It is very fast. Sometimes it is known as hyperacute rejection. There are three types of rejection. The first type is hyperacute rejection. Hyperacute rejection is within minutes or few hours. Within few hours, the graft is rejected. Sometimes I'm saying, on the OT table itself, before you suture the patient, before you suture the recipient, you come to know the graft is rejected. The complete graft become congested, highly vascular, highly congested, and looking grossly only you identify it's a gone case. It's an unsuccessful surgery and it is rejected. You can say, ma'am, how it is so fast? How it is possible? You are saying this is the recipient's body. Okay, this is the blood vessel of the recipient. Okay, this is recipient, not donor. And this is the graft. This is graft which we take from the donor. From the donor's body, we have transplanted it in the recipients. So you are saying as soon as you are putting it, it is rejected. How come so fast? So it is only possible if the recipient's blood have preformed antibodies for the antigens present on the graft. For the antigens present on the graft. If the preformed, I'm using the word preformed antibodies are present. Preformed antibodies are present in the blood of the recipient. This is recipient. You would say, ma'am, from where these preformed antibodies are present? So in that case, if you are transferring the graft from the donor to the recipient, as soon as you put it, place it, the antibodies are already present. They start attacking. And within few minutes, it got rejected. Okay, within few minutes, it got rejected. This is known as hyperacute rejection. I will tell you three types of rejection. This is hyperacute. The second is acute and chronic. I will tell you mechanism of all three. This is first one, hyperacute rejection. It is very fast. Within minutes, the graft is rejected on OT table itself before you close the patient, before you suture the patient. So before you close, you come to know the graft is rejected. It's a gone case, it's a flop surgery. Okay, so it is due to preformed antibodies. Now the question arises from where these preformed antibodies are coming. There should be a sensitization. Maybe the donor, this is a donor and this is a recipient. These two are relatives. And the donor has given blood to the recipient in the past. So the antigens of the donor are already exposed to the recipient and recipient have made the antibodies for that antigen. And body have immunology memory. There is memory. Immunology memory is present. That is forever. Once the antibodies are formed, it will be forever. For example, this can happen. So maybe the blood is given by the donor to the recipient in the past. Maybe donor have donated some other organ to the same donor have donated this some other organ to the same recipient because these two are relative. Maybe so the recipient body have make an antibody for that. Maybe the donor is the child and the recipient is the mother. It is quite possible that the child is giving the graft to the mother. This child is actually not child. It is a 25-year-old person maybe. And this mother, maybe she is 60-year-old. Now when she was pregnant, at that time, the child was a fetus and inside the uterus of mother. At that time, via placenta, because of the reverse blood flow, it may possible the little bit of the blood from the child is exposed to the mother. And the mother have make antibodies at that time. And they are remaining for years because of immunological memory. It can happen. So this is sensitization, the various routes of the sensitization. Ultimately, the preformed antibodies are there. And these preformed antibodies are killing the graft. They are rejecting the graft. This is hyperacute rejection. It occurs within minutes or hours. Okay, it is due to preformed antibodies. You get questions on that. How many of you got it? It is within minute to hours. Okay, so the complete blood vessels of the graft are thrombosed. It will be ischemia in the graft. And it is due to previous blood transfusion, previous pregnancy or previous organ transplant from donor to recipient. In most of the cases here, the donor and recipient are relative of each other. They are known persons. And that's why the donor has given the blood to the recipient or some other organ to the recipient, or donor is the child and the recipient is the mother. And while pregnancy, via placenta, the transfer have take place. How many of you got it? Give me a thumbs up. So this is hyperacute rejection. Can I come on the acute and the chronic rejection? I'm telling you the three types of rejection. Hyperacute, acute and chronic. How many of you got it? Everyone give me a thumbs up. Come on, interact. Say yes or say no, but say something, people. Say. So you got it? What is hyperacute rejection? Yes, this is hyperacute rejection. Now let's come on the acute and the chronic. For that you have to understand And the mechanism, we will come on that. First read this question and tell me the answer. Okay. Graft rejection due to preformed antibodies occurs in what? So it is a very common question. I guess everyone knows the answer right now. Preformed antibodies is occurring in hyperacute rejection or acute rejection or subacute rejection or chronic rejection. So preformed, the word to be picked here is preformed. So it will be very fast. Within minutes, it's hyperacute. So you frequently get this MCQs. MCQ in your exam. Very frequent question asked in your exam. Okay. Now coming on the acute and chronic. Okay. For acute and chronic, you have to understand two mechanisms of the graft rejection. Direct pathway, indirect pathway. Direct pathway leads to acute rejection. I will explain. Okay. And indirect pathway leads to chronic rejection. Hyperacute we have already seen. Okay, now let me explain the acute and chronic. There are three types of rejection. Hyperacute we have already seen. Now let me explain you the acute and the chronic rejection. For understanding acute and chronic rejection, you have to understand direct and indirect pathway. For that, you have to understand the immunity, the mechanism of immunity. I will come on that. Start from the basic. How many type of immunity are there? Anyone knows how many type of immunity is there? Say, ma'am, in human body, there are two type of immunity. What are the two type of immunity we have? Say, ma'am, we have humoral immunity. Humoral immunity, which is antibody mediated, and we have cell mediated immunity, in which T lymphocytes have a role. Currently, I'm interested in this one. How many of you know the mechanism of cell mediated immunity? You have to understand the mechanism of cell mediated immunity if you want to understand the pathways, acute and chronic rejection. So let me tell you the cell mediated immunity. Okay, imagine a antigen is entering a human body. This is the antigen. Antigen. For example, in my body, this antigen is entering. Who's the antigen? Any foreign particle. Not self, any foreign particle. Imagine this is the antigen. Antigen is a foreign particle entering in my body in a normal, healthy, adult human body. So I want to tell you the cell-mediated immunity. So this antigen is interacted. The first cell, it will interact as antigen-presenting cell. This is APC, antigen-presenting cell. The antigen-presenting cell will engulf the antigen. It will degrade the antigen into multiple pieces inside that. Process the antigen and present it on its surface. Present on the surface like this. That's why it is known as antigen presenting cell, APC, antigen presenting cell, APC. Now it will present the antigen to the next cell. It will present this antigen to the next cell. To which cell it will present? It will present it to helper TH cell. Helper TH cell. And it will stimulate the helper TH cell. Got my point? On stimulation, helper TH cell do three things. Number one, it will secrete the cytokines. Helper TH cell will secrete the cytokines. Many cytokines will come and cytokines will do three things. Number one, certain cytokines will stimulate CD4 lymphocyte, CD4 T lymphocyte, certain will stimulate CD8 T lymphocyte, and certain will stimulate B lymphocyte. CD4 T lymphocyte will cause delayed hypersensitivity and make a granuloma. CD8 T lymphocyte directly cause the cytolysis. It will cause the killing, direct killer. These are the killer cells. And B lymphocyte will make the antibodies. So this is how the cell-mediated immunity work in human body. I hope this is normal mechanism. It has nothing to do with the transplant. Now let me correlate with the transplant. Here the most important cell is APC. You have to understand. So tell me first tell me, how does cell-mediated immunity work in human body? Tell me the steps. Say, ma'am, first antigen come. The antigen go to APC. APC will engulf the antigen, degrade the antigen, process the antigen and present it on the surface. This APC will take the antigen to helper TH cell. On stimulation, helper TH cell secrete the cytokines. Cytokines stimulate three more cells. Which three cells? CD4 lymphocyte, CD8 T lymphocyte and B lymphocyte. So this is the mechanism of cell-mediated immunity. If you got this, please listen. If you got this, especially APC, now you can understand direct and indirect pathway. I'm damn sure out of the students who are watching right now and who will watch later the recorded lecture, many of them, they even don't know this pathway and it's very complicated. But I will make a fun for you. Please understand it clearly. Now let me tell you what is direct and indirect pathway here. Okay, let me tell you. So this is the donor. I'm not interested in donor. I'm interested in recipient's body. This is donor's body and this is recipient's body. Let me draw a bigger one. I want to explain the mechanism inside the recipient's body. Okay, this is donor. This is recipient. Let me write. This is donor and this is recipient. I will call the recipient as host. Okay, this is the host or the recipient. This is the blood vessel inside the recipient. Inside the recipient's blood vessel, this is helper TH cells. Helper TH cell. Let me draw. Helper TH cells. We all have immunity. So this is the blood helper TH cells present in the blood of the recipient. You will say, ma'am, okay, I got it. Now this is the graft. which I am taking from the donor and transferring it to the recipient's body like this. So this is a graft transfer we've done from the donor to the recipient. On the surface of the graft, antigens are present. These are the antigens, okay, which are known as epitopes. The antigens are present which are foreign for the recipient. Hana, now there are two possibilities. Please understand it very carefully. There are two possibilities. Hana, let's apply the cell-mediated immunity. Now you all can see this is the antigen. What is the first step? What's the first step? See, ma'am, first step is antigen presenting cell. The antigen presenting cell will come, engulf the antigen, process the antigen, degrade the antigen and present it to the helper TH cell. These are helper TH cell. So I want APC. APC, this is antigen. You can see this is the antigen here, okay? And you all can see this is the helper TH cell. I want APC that take the antigen, degrade the antigen, process the antigen and present it to helper TH cell. So I want APC. So where is the APC? Where is the APC? That will decide direct and indirect pathway. There are two possibilities. Sometimes the graft contain the APC. Let me draw the APC inside the graft itself. So these are the donor's APC. Hana? Donor's APC which are transplanted along with the graft. So donor APC only, they are taking the antigen, engulfing the antigen, processing it and presenting it to the helper TH cell. This is known as direct pathway. In the direct pathway, the APC is of donor only. The donor APC are degrading the donor's antigen only and presenting it to the recipient's helper TH cell. This is direct pathway. The second possibility, the recipient's APC are there. Recipient APC. Recipient APC will come here. They will take the antigen, degrade the antigen, process the antigen and present it to the recipient's helper TH cell. This one is known as indirect pathway. Direct pathway leads to acute rejection and indirect pathway leads to chronic rejection. First, you tell me how many of you got it. The person who got it, give me a thumbs up. Let me ask vice versa. How many of you didn't got it? Write down clearly, ma'am, I didn't got it. Please repeat. How many of you? That didn't got that? What is direct pathway? What is indirect pathway? So basically the direct and indirect pathway depends on APC. APC of donor or APC of recipient. Antigen presenting cell. APC of donor or antigen presenting cell of recipient. Whose APC is taking, engulfing the antigen. Here also we have the antigen. Antigen is the foreign particle. Here also we have the antigen. The antigen is the foreign particle. Hana? So here the APC of donor is engulfing and processing and presenting it to helper TH cell. Here the recipient APC is processing and presenting it to helper TH cell. The helper TH cell is of recipient only. The helper TH cell, once stimulated, it will stimulate the three things by secreting cytokine. The CD4 lymphocyte, CD8 lymphocyte and B lymphocyte. Here also CD4, CD8 and T lymphocyte. Rest of the thing is same. But it is the APC that matters. So if it is the APC of donor, it's direct pathway. And if it is of the APC of the recipient, it's indirect pathway. I must say it is the most difficult thing to understand in the transplant immunology. So that's I want to explain you. Okay, I hope everyone got it. Anyone who wants me to repeat this concept again? You can see this is the APC, antigen presenting cell. This is the recipient's APC. Okay, so this is indirect pathway. And here, this one is the donor's APC, you can see. This is donor's APC. So this one is direct pathway. So who is presenting? Ultimately, it is stimulating the helper TH cell. Once the helper TH cell is stimulated, it is CD4, CD8 and B lymphocytes are activated in both the cases. So rest of the story is same. Rest of the story is same. You don't want me to repeat? You people are too intelligent. Everyone got it? Superb. So this is the mechanism. So we have two pathways, direct and indirect. Okay. In the direct pathway, it is the donor's APC. The APC which are already present in the graft. Graft means donor. The graft is coming from the donor. So graft APC means donor APC. That is processing. Hana, graft's APC. By graft APC, I mean donor APC. I mean donor APC. Donor APC and graft APC are same. That is presenting to the helper TH cell. Okay, this leads to acute rejection. And the second is recipient's APC. That is presenting to recipient's helper TH cell. And this leads to chronic rejection. How many of you got it? Can I summarize? Let me summarize. Chalo, we will do the summary. So let me tell you the rejection of the graft. The three type of rejection we will see. Okay. You have to understand there is a donor. Okay. Who is giving the graft. And there is a recipient who is receiving the graft. So let me draw the recipient. Okay, so this is a donor and here you can see this is a recipient. The donor's body, the recipient's body. So we are taking, so there are three types of rejection I will show you here. So this is the graft. We are transplanting the graft from the donor to the recipient like this. We are transferring it. Hana? Now this is the recipient's blood vessel. Okay, inside the recipient blood vessel, you can see this is the This is the helper TS cell. Okay, this is the helper TS cell. Now, there are three mechanisms by which this graft is rejected. Number one, in the recipient's body, sometimes preformed antibodies are present. Preformed. These are preformed. I will name them preformed antibodies are present due to the sensitization of the recipient by the donor previously, before the this transplant. So this preformed antibodies are coming and damaging the graft. This is known as hyperacute rejection. The first type of rejection is hyperacute. It is due to preformed antibodies. It is within minutes. As soon as you put the transplant, it is rejected on the OT table itself before you suture and close the patient sometimes. Within 24 hours, it is completely rejected. Okay, so this is hyperacute. Okay, the second time is acute and chronic. Let's talk about the acute. In the acute, there are APCs present in the graft itself. These APCs present in the graft itself are of donor's APC. They will engulf the antigen, process the antigen and present to helper TS cell of the recipient. This is acute rejection. The acute rejection is leading it is acute rejection. It is the direct pathway which is leading to acute rejection. And sometimes it's recipient APC. It is processing the antigen and presenting it to helper TS cell. This one is known as indirect pathway. It will lead to chronic rejection. So finally, we are having three types of rejections: hyperacute, acute, and chronic. The summary is that hyperacute is due to preformed antibodies. The hyperacute is due to preformed antibodies. The acute is due to direct pathway, and chronic is due to indirect pathway. This is the summary. If you got the mechanism, very good, excellent. If you didn't got it, it's okay. Learn the summary. Learn the summary. Okay, can we go ahead? Say, give me a thumbs up. Got it? Happy? Got it? So this is the thing. So ultimately, in both the pathways, on activation of helper TS cell, the cytokines are released. The cytokines will lead to activation of CD4 lymphocyte, leading to delayed hypersensitivity, CD8 lymphocyte leading to cytotoxic effect, and B lymphocyte leading to antibody mediated mechanism. So CD4, CD8 and B lymphocytes are stimulated in both of them. So this is the summary. Okay, so let's come on the next, how to prevent the graft rejection. We have seen the three types of graft rejection, how to prevent it. Now I'm a surgeon. This is my recipient. I do not want the rejection. Okay, so this is the graft which I have transferred from donor to recipient. From the donor's body to recipient, I have transplanted. Okay, I do not want the rejection. So I can do two things. I can prevent it. I can prevent it via doing two things. Number one, before this surgery, before this transplantation, I can do the HLA matching of the donor and the recipient. So if maximum matching is there, chances of rejection are minimum. If multiple donors are available, maybe 3, 4, 5 donors, so I will select who is the best donor for this person by doing the HLA matching of all of them. And if the donor is identical twin, there is no problem at all, because HLA matching in such cases is 100% and there is no chance of rejection. Got it? So first thing we can do is the HLA matching. HLA matching. And you may be knowing for the transplant, ABO matching is also required. So the same blood group person only can transfer the transplant. I mean, the blood group of the donor and recipient should be same. Okay, if the donor is the blood group, recipient is blood group A, we need a donor of blood group A only. If the recipient is blood group B, we need a donor of blood group B only. So if the recipient is O, we need O. If the recipient is AB, we need AB. So ABO matching is also required. So ABO matching with HLA matching. So we want this combination to minimize the chances of rejection. And the second thing, we can give the immunosuppressive therapy throughout the life after transplant. So in immunosuppressive therapy, we are having many drugs available. There are corticosteroids, there are mitotic inhibitors, MTOR inhibitors. There are many drugs, you read it in pharmacology. And there are many monoclonal antibodies are also present. You can see the various monoclonal antibodies are present that prevent the rejection. Okay, the last thing I want to teach you here is graft versus host reaction, GVHD. Let me explain. It's very interesting. Please understand. And it's difficult. So listen. Till now, what was happening? You tell me. This is donor and this is recipient. Now reverse will happen. Listen. What was happening till now? First understand normal. So you tell me, ma'am, normally this was a donor. This was a recipient. This is the blood vessel of the recipient. We are taking the graft from the donor to the recipient like this. Okay. Now, the immune system of the recipient is rejecting the graft. Who is rejecting the graft? I will call the recipient as host. So, host is rejecting the graft. So, what was happening normally? The host, that is recipient. Host and recipient is one and the same thing. So, host was rejecting the graft. Okay, because host immune system is very powerful and it was finding the graft as foreign. So, anything foreign comes in my body will reject it. So, it is happening in the recipient. So it is the host who was rejecting the graft. It is known as host versus graft reaction. Host is rejecting the graft. I repeat, host is rejecting the graft. Now, sometimes, rare of the rarest, what happens now? This host is immunosuppressive. For example, the person is having AIDS. So immunity is very weakened. है Immunity is weaned off. The immunity is weakened. The lymphocytes are not there. The lymphocytes, or the patient is on steroids, or the patient is having chemotherapy, or the patient is having any other immunosuppressive disorder. Okay, so here the lymphocytes are absent. So here host cannot reject the graft. Host cannot reject the graft. Okay, number one thing, this is happening. Okay, I got it. Host cannot reject the graft, number one. Number two, the graft in the same person. The graft is immunocompetent. Maybe this graft is of bone marrow. This graft is bone marrow, which I am transferring from here to there. So bone marrow contain the immune cells. Na? The bone marrow contain the immune cells. It is containing the lymphocytes. Okay. So here the lymphocytes are not present in the recipient because recipient is immunocompromised. The lymphocytes are present in the graft. So here the recipient will not reject the graft. The graft will reject the recipient. The graft, the lymphocytes present in the especially the T lymphocytes. The T lymphocytes present in the graft, the bone marrow graft, that will reject the various organs of the recipient. So here the graft is rejecting the recipient. It is known as graft versus host. Recipient is host. Graft versus host reaction. GVHR. How many of you got it? It's reverse. है ना, तू क्या मुझे रिजेक्ट करेगा, मैं तुझे रिजेक्ट करता हूँ. दिस इज द पॉइंट, है ना, कि रेसिपिएंट इज नॉट रिजेक्टिंग द ग्राफ्ट. ग्राफ्ट इज सेइंग कि मैं तुझे रिजेक्ट करता हूँ, मुझे तेरी बॉडी पसंद नहीं आई, है ना. सो द रेसिपिएंट इज रिजेक्टिंग द ग्राफ्ट. This is known as graft versus host reaction or graft versus host disease. It is reverse. So for happening GV, graft versus host disease, two conditions are required. Number one, the recipient is immunocompromised. The immunity should be weaned off, immunocompromised. That's why recipient cannot reject the graft. And the graft which you are transferring from here to there, it should be immunocompetent. It should contain the T lymphocyte, the bone marrow graft. Then only this is possible. Then only. So please learn the two conditions. Please learn the two conditions of GVHD. You get question on that. The recipient must be immunocompromised. Okay? Immunocompromised. And the graft must be immunocompetent. Immunocompetent. This is immunocompromised. This is immunocompetent. By immunocompetent, I mean it should contain T lymphocytes. So it is the bone marrow graft. It contains the T lymphocytes. Shall I repeat or you got it? Shall I repeat or you got it? I repeat. Huh? Say, give me a thumbs up. Otherwise, write down, ma'am, please repeat. You got it? What is GVHD? Huh? It is reverse. Ulta hai. Tu kya mujhe reject karega? Main tujhe reject karta hu. So here, if you are transplanting a graft containing the immunocompetent cells, है ना? So here, the graft is rejecting the host body because host is immunocompromised. So the graft is mounting an immune response to the host, in contrary to the usual situation where the graft in most of the graft rejection, where recipient is mounting an immune response on the graft. Here it is not that. The graft is mounting an immune response on the recipient. It is also known as run disease. GVHD also known as run disease. So one and the same thing. Got it? So here two conditions are required. I told you the graft must contain immunocompetent T lymphocyte, not B. And the recipient must be immunocrippled, immunosuppressed. Then only GVHD can happen. Now read the question and you tell me the answer. Who will read the question and tell me the answer? Read the question. So graft versus host reaction occurs only if. When they will occur? Graft versus host reaction occurs only if the graft contain immunocompetent B lymphocyte, yes or no? Huh? Graft contain macrophages, yes or no? Recipient must not reject the graft, or recipient is not an immunosuppressive drug. What is the correct answer? You use your common sense first and you tell me, when does GVHD will take place? When does it will take place? So Ranjana, Bisma, Prakash, Sri Devi, Taba, anyone can tell me. Huh? I cannot read all your names. You can tell me what is the correct answer. From A, B, C, D, write down A or B or C or D. What do you think? What is the correct answer? So for GVHD, graft must not contain B lymphocyte. No, they should contain T lymphocyte. They should not contain macrophage. No, they should contain T lymphocyte. So these two options are incorrect. The patient must be on immunosuppressive drug. Hana, so this is also incorrect. But yeah, only one sentence is correct. The recipient must not reject the graft. Yes, because the recipient is immunocompromised. Yes, so C, no, not A, not B, not D. You all are wrong. And it's a tricky question. It's a tricky question. B lymphocyte की जरूरत नहीं है. We need T lymphocyte. है ना, in the graft. Macrophage की जरूरत नहीं है. We need T lymphocyte. ठीक है, और रेसिपिएंट को तो इम्यूनोसप्रेसिव पे होना चाहिए. Then only it will be immunocrippled. Got it? But recipient must not reject the graft. Then only graft will reject the recipient. If recipient will reject the graft, it is the usual situation. This is not GVHD. Huh, no, we want usual. We want GVHD. We do not want usual. In usual situation, recipient reject the graft. Here, graft is rejecting the recipient. So basically, recipient is not rejecting the graft. Huh, no. So correct answer is C. How many of you got it? It's okay if you're doing the mistakes here. Better to do the mistakes here, not in exam. If you're doing a mistakes here, I'm happy that you will not repeat the same mistake in the exam. You will learn from that. So please understand it. If you still have doubt, please write down clearly. I will repeat. You got it? Why the answer is C here? Why not A, B and D? So we are done. We have seen the transplant completely. You know everything about the transplant now. Yes or no? You know the various types of the transplant? The 4 types of the transplant I told you. I told you what is autograft. I told you what is isograft, also known as syngraft. What is allograft? What is xenograft? You get many questions on that. Believe me. You got the various types of rejection, the mechanisms, hyperacute, acute, and chronic. Hyperacute is due to preformed antibodies. Acute is due to direct pathway. Chronic is due to indirect pathway. I assume you all know what is the meaning of the direct and indirect pathway. And you know the prevention, the 2 ways of prevention, HLA matching and immunosuppressive drugs. And you know graft versus host reaction. I hope you all got that. Okay. Now, if you want the notes of this session after the session, when I will end this session, after that in the same YouTube channel where you are watching right now, in the comment, you will see a link. The link will be pasted after the session is ended immediately right now. Okay. So the link will be pinned there and you have to click that link. You will get the notes of this session and not only this session, all the sessions which I have taken on YouTube yet now. Okay. So you can get the notes. So please take the notes. Or otherwise what you can do, there is a QR code. You can scan it. I'm giving you time or you can take a snapshot and later on you can scan it. If you scan it, you will be diverted towards my website, that's MedLive by Dr. Priyanka, where also you can get the same notes which I'm talking about. And along with the notes, you can connect with me on various social media platforms, that is Instagram, WhatsApp, Telegram, where I daily share many education related material, the reels and many things, the PYQs, the IBQs, which are important for the medicos, specifically medicos, for their competitive exams and university exams. So it will be highly useful for you. So you can join me if you wish. And there is a contact number is also given. You can save it if you wish. It's 9833032948. Please save it. So this number is available for the chat support, not for calling. Okay. So if you have any doubt, please text it. It's available on the WhatsApp as well as the same number on the Telegram, the same number on the WhatsApp, the same number for the SMS. Okay. So please text your query, whatever your doubt, your query, whatever I'm teaching you. If you have any doubt or if you want any topic to be taken on YouTube live by me, please, you can request that topic also. So if many students are requesting the same topic, we can schedule it very soon. Okay, so thank you so much for your support and for your patience, your time. Wishing you all the best. Every Tuesday and Friday, we take live sessions 9:30 a.m. in the morning. Okay, so today's session is done. Now the next session, the last session of this month is on 31st of January. That is chronic inflammation granuloma formation. So I will teach complete TB also here, the complete granulomatous inflammation, everything about the chronic inflammation, about the giant cells and everything we are going to take here. So it's a very important topic. Don't dare to miss it. From the next month, the timings is not in the morning. It is in the night, 10 p.m. to 12. 10 to 12 in the night, because many students requested me that in the morning they have colleges. In the college, they can't attend the lectures and they want to attend the live session, not the recorded one. So that's why we shifted the time from the morning hours to the night hours. From the next month, that is February, we will take the sessions in the night. Okay, the free sessions. So whatever topic you want, please text me on the contact number I have given. If you have any topic in your mind from pathology, pharmacology, microbiology, community medicine or medicine, please text it. We will schedule it very soon. Thank you so much. Wishing you all the best. Okay, I'm ending the session. I hope you learned, enjoyed. So just want to wish best luck to all of you. Thank you. I'm ending the session. Bye-bye. All the